Hello, Dental TV viewers. I'm Dr. Kim Tae-eun, MC of this session. Clinically, we sometimes encounter very challenging cases and we are not sure how to deal with them, how to set up the treatment plan, whether I'm doing fine or not. So in the case discussions, we are going to share these issues and we are trying to find the optimal solutions. Case discussion 1. We have invited 3 dentists. Let me introduce them. First, from Setmoa Dental Office, Dr. Jung Jong-chul. Hello, I am Jung Jong-chul. Thank you very much for inviting me to this wonderful building, and it is my honor. I'm not perfect, but I hope to be helpful to you through this session. From Samsung Seoul Hospital, we have invited Dr. Yang Seung-min. I also feel pleased to be invited to this wonderful building with other colleague doctors, and I believe this is a good opportunity to suggest some good answers in a challenging cases. I know them, but this is my first time to be in a session like this, so I'm a little bit nervous. Next, we have Dr. Son Young-hee from Kumpo Ijon Dental Hospital. Hello. It is my honor to be invited here in this session where renowned doctors, dentists are together. I will do my best to be of any help to the audience. Thank you. Now let's go into the case discussion. We received some questions from the dentists if they have encountered any very challenging cases. Today we are going to talk about very complex cases requiring sinus lifting. Let's think about that together and look into solutions. The first case, the patient is 44-year-old male. No mental illness history. The plan is to place implants on both jaws, especially on the posterior of upper left. There's cystic lesion in the sinus. On the CT X-ray, blood vessel is running on the side wall of sinus. How can we establish a treatment plan? I am lost here too. What is the good idea when it comes to planning the treatment? Dr. Chung, would you like to go first? If you look at this case, I see there are 3 problems, especially on the upper left. Placing implants would be a problem. The biggest problem is that the residual bone is very thin, like 1 millimeter. This requires window approach and 2-staged approach. Bone graft should be done first before implants are placed. If you look at the CT X-ray, cystic lesion is observed in the sinus. On the left side wall, blood vessel is running. So those are the 3 problems you need to be addressed to place implants. And how can we wisely overcome the obstacles? That is the important point. I think so too. So the dentist gave this as a problem. I believe he has an experience in the area of maxillary sinus and he knows what needs to be done, but the residual bone, not much there. And the blood vessel is running. In the past, if we did not have the CT, we could just go in there, but as the blood vessel is showing on the CT, that can frighten a surgeon a little bit, but I don't think we need to be too much worried about that. Yes, there multiple problems, not an easy case for surgery. What about Dr. Son? Looking at the case, the actual problem, as others said, the residual bone is not much, so it's not a case for one-stage approach in terms of the initial stability. I believe stage approach is the right one. And if you're skilled in window approach, we need to think about how to get rid of cystic lesion. Is it going to be raised with membrane raising, lifting, or we are going to aspirate it out before bone grafting? That would be the issue we need to determine. Thirdly, in the sinus wall, intraosseous anastomosis artery is observed. So how can we deal with that? Those are the three problems. First, the consensus regarding this does not exist. So depending on the situation and depending on how we approach it, things will be different. If it were my case, the cystic lesion will be removed with aspiration before bone grafting. Secondly, intraosseous anastomosis artery. On the CT, it is not completely intraosseous. It runs windingly in the external wall of sinus, so if we can avoid it during osteotomy, I don't think it will show bleeding tendency, so osteotomy line should be carefully planned. And cystic lesion is aspirated and bone grafting is done in a staged approach. I'm not saying that's the only correct way. Thank you. Many doctors have difficulties when it comes to the window approach. Cystic, pathologic lesion, unknown lesion may exist, and people are wondering whether window approach can work well. Sinusitis can occur after window approach, and I discussed this with many doctors, and I find many people are afraid of bleeding with the window approach. If a vessel is greater than 1 millimeter in the internal wall of sinus, often bleeding cannot be stopped with applying pressure. So people are wondering what we need to do, so they tend to use crystal approach. In this case, window approach is a must, and in many cases, window approach is required. Therefore, we need to learn and get skilled in the window approach. That's what I'm thinking often. I believe you have a more experience clinically. Window approaches always makes me nervous whenever I do it, especially when a patient situation is not very good. When there is cystic lesion, how do you choose aspiration versus raising the membrane? So I have prepared some slides for that. These are the most common complications of sinus elevation with window approach. Sinus membrane perforation for various reasons. Especially when there is a cystic lesion, perforation can occur more. Next, the bleeding. Intraosseous artery. If the artery is 1 millimeter or more, the bleeding cannot be stopped easily, and rarely implant can migrate into the sinus. As you know very well, intraosseous artery, usually it's 19 millimeters above the crestal bone. Intraosseous artery runs in various ways like this. and we need to do the bleeding control carefully depending on the situation. And we are afraid of some of the situations. If the vessel is in the thick bone, blunt instrument can be used to apply pressure to stop bleeding. But if the vessel is in the internal wall of sinus, applying pressure would not work. So we need to use a Bovie instrument for electrocoagulation. The vessel is running in the outer wall of sinus. When it bleeds, first we need to apply pressure for 3 minutes. The time is important and the people get nervous seeing the bleeding. In less than a minute, we tend to lift up the gauze. That's not a good way. Therefore, you need to apply pressure for 3 minutes. You'd better use a timer for 3 minutes. Mostly, it can be stopped unless the blood vessel is too big. If the bleeding does not stop, you need to use a Bovie electrocoagulation. Then mostly the bleeding will stop. When you do sinus surgery, Bovie needs to be there when you do the surgery. There are various cystic lesions like this, especially the mucosal aggressive cystic lesion. If it is not that aggressive one, window approach can be used. The biggest problem with a cystic lesion is that internally it's sloshing, so the membrane can easily get torn apart. So when you do the aspiration during the sinus elevation, you can do it easily. This is the picture showing that. When you do the aspiration, the thickness of the needle should be thick, like 18 gauge. The commonly used thin needle would not work for the aspiration, so you need to repeatedly do the aspiration as you lift up the sinus membrane. This is a similar case. There's a cystic lesion on the CT X-ray. This is similar to the case under discussion. There is a cystic lesion. As you aspirate, there are two benefits. The sinus lift can be done easily, and if you look at the exudate in the cystic lesion, you can tell whether there is infection or not. When you do the aspiration, when you see suppuration and the signs of infection, you need to do copious irrigation, cleaning before you do the bone grafting. And implants are placed like this. And if the cystic lesion, according to many papers, if the cystic lesion is more than a half of sinus membrane, sinusitis can occur more often according to the reports. So if we are concerned about that, we need to do the aspiration in a simple way by perforating from the outside. After 3 or 4 months, we can do the window approach. The method is very simple. We make a vertical incision on soft tissue with a round burr, penetrate into the external wall, and perform aspiration 2 or 3 times. And we aspirate with needle suction and suture. In 3 or 4 months, cystic lesion is reduced more than a half. Then a window approach can be done quite easily. Thank you. I believe this has been very helpful to the doctor who raised this issue. When I do the window approach and the bleeding cannot be controlled, I get very nervous. but what you said is very helpful. You said we need to keep applying pressure for about 3 minutes. That was a very good tip. When there is cystic lesion and I have been struggling what I need to do when I do window approach, aspiration needs to be done during the sinus elevation. And personally, that has been a very good explanation. Do you have anything more to add to this? That was very well explained. Yes. What about Dr. Sun? Do you have any other approach? I do almost the same as you, but if I may give you a tip, when you do the aspiration, people are afraid of doing it. When you do aspiration, the material inside the lesion exudate. There are two types, enterosudosis and mucosal retention cyst. So aspiration should be different depending on the type of exudate. As you saw in the case, the yellowish exudate is mostly from enterosudosis. For mucosal retention cyst, if you do needle aspiration, that wouldn't work. Therefore, I usually use 10 cc or big syringe without needle to do the aspiration. You can do the aspiration much better. So depending on the cyst type, you can use a different aspiration. For mucosal retention cyst, it is important to remove it completely. So you need to do copious irrigation. Nothing of it remains. If you are not comfortable still, you can mix antibiotics to the cell line to prevent infection. What sort of antibiotics to use? Amoxicillin or augmentin? Augmentin is not easy to subdivide, therefore amoxicillin will work okay. Personally, I use tetracycline capsule that's easy to use, that is mixed with the cell line. Sometimes doctors are worried that the membrane can be torn apart when you penetrate a needle into it. I don't think you need to be worried about that. Even though it is penetrated with a needle, the membrane is lifted and it gets folded, so they overlap. That's no problem. Still, if you're not comfortable with that, resorbable membrane can be applied over it, so it can be covered with a resorbable membrane. I have a different approach, mixing antibiotics. I don't think it has an evidence, and we use that based on our empirical experiences. I do a lot of irrigation with cell line. So the copious the irrigation is, the better, I believe. If you prepare antibodies like tetracycline or amoxicillin, we need to have the prescription for that. Rather than that, when problem occurs, copious irrigation helps better. Cyst perforation, you don't need to be worried about that. Inside of it is a lesion, so we are penetrating into the cyst external wall, not into the sinus membrane, and you can be a little bit aggressive to insert the needle. I'm not saying you need to go beyond the cyst region, so you can go into the cyst rather aggressively to get rid of the exudate. So using antibiotics is important, but more importantly, cleaning is very important. I believe it's basically the same thing, but what I said is easier to do. I agree with Dr. Yang. Mostly, I use copious saline irrigation, but sometimes I use antibiotics. The cystic lesion is sometimes infected and suppuration comes out. In that case, I don't just use saline. It is mixed with antibiotics, with irrigation, and then saline irrigation. That's my personal approach. Cystic lesion, when I do window approach, I have been always nervous about that. Listening to this explanation, I think I can do better in the future. I believe the dentist who raised this issue is helped a lot by this discussion. Let's go to the next discussion. The second case, patient is 61-year-old male. On the left, the issue exists, sinus pneumatization and atrophic alveolar ridge on 25 and 26. And there's no dental or medical history. Number 25 and 26 are planned to receive implants, but as you can see on the CT X-ray, the bone is very thin. Let's have a look at the intraoral picture. In this case, how do we need to approach? Vertical bone volume is very small. Dr. Son? If you look at the case, I believe just a short time ago, at most 3 or 4 weeks ago, the extraction was done. And bone graft in this situation is very challenging. The extraction was done just a short time ago. So alveolar ridge height is absolutely low. Vertical implant positioning is very challenging. Secondly, if the extraction was done too long ago, implant housing cannot be established even with a sinus graft. So in both cases, vertical or horizontal augmentation GBR is needed simultaneously with sinus lifting. This is a very challenging case. In my case, alveolar ridge, alveolar process should receive GBR as well, and sinus graft should be done simultaneously as well. I will do sinus graft using a lateral approach, and augmentation GBR will be done at the same time. An implant placement will be delayed for about 4 months to place them in ideal positions. In that case, I encounter such cases from time to time. Ridge augmentation is done, and sinus elevation is done before implants are placed. The implants are also integrated, but the prosthesis, the shape is not favorable. Dr. Yang would encounter peri-implantitis much more than me. Unfavorable prosthesis would lead to peri-implantitis. Like Dr. Son, vertical ridge augmentation should be done simultaneously, in my view. I agree with that. My colleague doctors are experts and they are capable to address such problem. But like the doctor who sent this issue to us, people sometimes don't know their capability and struggle thinking up to what procedure can I cover. It also depends on your clinical goal. Is it osseointegration or plus good prosthesis shape? So it depends on the goal of the treatment. Ideally, as you said, vertical height should be increased for stable lifespan of the implants in the future. These days, one of the most important implant factors is after placing implant, osseointegration and prosthesis. That's not the most important thing. 5, 10, 20 years of stable use of prosthesis is very important. Now people expect to live 100 years. And patients with problems always come back to us for peace of mind, even though it is a little challenging. Ideally, good osseointegration, ideal prosthesis, fabrication to reduce the peri-implantitis. That type of treatment can be the goal. Surgery and the prosthesis should be ideal so that patient can use it for a long time. So it's a grave responsibility on the part of a surgeon. Dr. Song, you said for this case in question, teeth looked extracted only 3 or 4 weeks before. If so, when do you think lateral sinus lift and vertical ridge augmentation should be done? Just for the GBR, according to the consensus report on implant regenerative outcome, 4 weeks after extraction, at that time, regenerative outcome is the highest. If you think you have slow hands and you don't think you can do sinus lift and GBR together, you need to do GBR 4 weeks after extraction. And when you place implants, you can do the crystal approach. So you can do the sinus lifting at that time. That is one way. Personally, if I'm determined to do GBR, in a certain case, 4 to 6 weeks after extraction, I do GBR at that time. Soft tissue is healed to a certain degree, so it's easy to get the primary closure. According to the papers, the outcome of GBR is the highest. So I try to use that timing. Thank you. I think a little bit differently. 4 weeks is too short. 4 weeks after extraction. Depending on the patient, the healing capability would be different, but it depends on the maturity of soft tissue. That determines the success of GBR. So I let the soft tissue mature 2 to 3 months. Then suture can be done more easily and the soft tissue tearing can be reduced. So 4 weeks is a bit too early. So I'm conservative. So I wait for 3 months before GBR. I think Dr. Chung must be right. In that case, 3 or 4 weeks after extraction, and the soft tissue is not really quite healed, so I need to be careful. I don't think determining the definitive waiting time is that important. If the case requires a staged approach, wound dehiscence should be avoided. So, maturity of soft tissue is very important. Rather than defining the timing, 4 weeks or 8 to 12 weeks can be good, but we need to determine intuitively. If you look at the soft tissue, can I get primary closure pretty well? I don't think so in this case. When the distal rather than the mesial side of the extracted tooth gets matured, I believe it is easier to deal with the soft tissue. So 4 weeks or 8 weeks sounds good. But in this specific case, can I do the primary closure If it were me, it looks like it's number 4 rather than number 5, number 6 or 7. At number 6, the soft tissue maturity looks very good. With that level of maturity, we can do GBR. Okay, the maturity of soft tissue can depend on the situation before extraction. So we need to intuitively determine the maturity of soft tissue for GBR. If I may add, I have prepared a similar case. This patient at the left upper posterior vertical ridge augmentation is required. If you look at the X-ray, CT, and panorama, especially at number 6, vertical bone defect is quite severe. Because of that, the maxillary sinus crest of bone looks very thin, 1 or 2 millimeters. As we discussed in this case, a window approach together with vertical ridge augmentation can be done, and then wait 4 to 5 months before placing implants. That can be the safest way. In the upper posterior, a window approach is challenging, and vertical ridge augmentation is challenging too. In most cases, we don't do vertical ridge augmentation often in the upper posterior. In this case, a window approach is used. The lateral wall of the window, if the wall is thick, which is autogenous bone, that bone is taken and used in the ridge augmentation. The autogenous bone is put over the alloplastic or xenograft. After that, resorbable membrane is applied. Then autogenous bone is mixed with the alloplastic or xenograft in the ridge augmentation, which is more stable. And we wait 5 months before placing implants, and the final prosthesis is delivered. That would give a more stable outcome. I can see the post-op picture after prosthesis is delivered. I can see you made a lot of efforts for that case. I believe the patient can use that for a long time. We did the vertical ridge augmentation, so we could have a more ideal prosthesis fabrication. So cleaning is done more easily, and the stable long-term outcome was achieved. Prosthesis looks very pretty. Do you have any further comments for the first or the second case? As for the second case, it's much more challenging than the first one. So it is important to up to what procedure you can do. If you cannot do them simultaneously, even though Dr. Jung did that at the same time, vertical ridge augmentation must be done first. As other doctors said, we need to wait until it becomes stable. I wait more than 6 months because of the graft material that I use is different. After waiting 6 months or more, as it is vertically augmented, the sinus lifting the size can be reduced. If you can do all of them simultaneously, it's better. But if it is challenging, you can use the staged approach, GBR first, and sinus lift can be done with implant placement. If you do them all together at the same time, you can get very nervous. You don't have to follow our solutions. So, staged approach might be better. I agree with Professor Yang, these days, stable implant is more important than fast implant placement. If you are afraid of doing surgery, simple vertical augmentation can be done first. Once the residual bone is 4 to 5 millimeters, crestal approach can be done simply with a CAS kit. That can be a good option. The first case involved a cystic lesion and vessel. The second case was about deficient vertical height, and you recommended a staged approach for both cases. As they are very challenging cases, we need to take time. Cystic lesion control was also explained, and how to deal with the bleeding. That was very helpful. When the vertical bone deficiency is severe, sinus bone graft as well as vertical augmentation need to be done for stable prosthesis. So there was a very good discussion. This is the first discussion. I wonder how the viewers have felt about this. I would like to thank those who raised the issues and also discussed other than the cases raised. I hope this has been very helpful. I am Dr. Kim Tae-eun. Thank you very much. I learned a lot from this session. Thank you.
감사합니다. 저도 공부 많이 했습니다.